So good evening, everyone. My name is Dr. Navneet Tewatia, and on behalf of FIND and PATH, I welcome you all for today's session on surveillance of SARS-CoV-2 towards pandemic preparedness in India. This is the second webinar which we are doing in partnership with PATH and through the initiative which is supported by PATH and Rockefeller Foundation. Today, we have a panel comprising of senior scientists and experts, and we also have an announcement about the documents we are coming up with out of the project which we are running with PATH and Rockefeller. To take the agenda forward, I would like to invite my colleague, Dr. Archana Beri. Dr. Archana is a clinical microbiologist trained in infectious diseases, laboratory medicine, and hospital and laboratory quality systems. Dr. Archana has joined us in FIND in January 2021, and before that, she was working with US CDC. So with this, I would like to have the honor to invite Dr. Archana to start with the panel. Thank you very much.
Thank you, Navneet, for a lovely introduction and a very warm welcome to all our webinar participants and our esteemed panel of experts. I'd also like to thank FIND for having me moderate this session, as it's not just a pleasure to be here, but also an honor to be a part of such a learned and august panel that we have today. Without any delays, moving on to our webinar, I think it would be apt for one to say that COVID-19 has consumed a significant part of everyone's everyday life. And since our first case, which was detected in January 2020, we've had 2 waves since, with over 30 million cases and 400,000 deaths. We are unsure of a third wave and whether we are or whether we will be prepared for a third wave. So today's webinar is structured in such a way so that we are able to touch upon various aspects of surveillance, specifically genomic surveillance in our country, with a focus on whether we are epidemic ready. We have today a very panel, and I would like to quickly introduce them. We have Dr. Samiran Pande, Dr. Tanu Anand, Dr. and Professor Priya Abraham, Dr. Rajesh Pande, Dr. Shibhu Vijayan, Dr. Daniel Bausch. And not only I welcome you all today, I would also express my gratitude to take out the time from your busy schedules to collectively talk about this important topic today. I think the most appropriate way to start today's webinar would be to get an understanding of the epidemiological setting of COVID-19 in our country, and no better than Dr. Samiran Pande and Dr. Tanu Anand from ICMR, who can provide us this context. Dr. Samiran Pande is the head of epidemiology and communicable diseases, ICMR. He wears a dual cap and is also the director of National AIDS Research Institute, Pune. Dr. Pande is an astute clinical researcher of more than 25 years. His training is from Calcutta National Medical College, School of Tropical Medicine, Kolkata, Christian Medical College, Vellore, and University of California, Los Angeles. His forte is in evidence-based policy decision and program development. He has authored numerous publications He is the recipient of Best Scientific Award for Communicable Diseases by ICMR in 95 and Fogarty International Fellowship Award in 95-96. Dr. Panda has sent his regrets for not being able to attend today's webinar in person because of some commitments towards the pandemic. However, he has been very generous to send us a recorded message and a video, and also have Dr. Tanu Anand here, who would be representing the division of ECD ICMR. Dr. Tanu Anand, you're welcome. She is an MD in community medicine. She's scientist D in Division of Epidemiology and Communicable Diseases, Clinical Studies, Policy and Protection Unit at ICMR, New Delhi. She's currently the Member Secretary of Epidemiology Surveillance Working Group for National Task Force COVID-19. The question that we had asked the ECD division, Dr. Samiran Panda and now Dr. Anand here, is how has COVID-19 epidemiology evolved over a period of time in India, and how has it shaped the response to the pandemic? And how can we use this epidemiological learning to prepare for future outbreaks? I would request Navneet to play Dr. Samiran Panda's message first, and then would request Dr. Tanu Anand to take over the question.
Good afternoon. I welcome all of you to this webinar, which has been organized by FIND and is supported by PATH and Rockefeller Foundation. This is very, very important and timely because India completed its 4th National Serological Survey, and we know that there is a ray of hope, but there is no room for complacency. The vulnerabilities do exist in different states, so it's time that we move on to state-specific surveillance. That's the need of the hour. And the sentinel sites need to be established at not only urban settings, but also rural settings. The other important thing that we should all try to ponder on is the need for genomic surveillance. However, time is the essence. We cannot afford to do a genomic surveillance and not quickly come out with the result that could inform program planning. So how do we pair up the clinical and epidemiological information collected during the sentinel surveillance and the genomic surveillance data in order to inform program will be the key for future. Thirdly, and most importantly, networking and partnership is something which is essential for us to be successfully able to manage this pandemic in future. We should not assume that we are protected. We are still in the middle of the second wave. Some of the states are even showing the indication for an upward surge, which could be the forerunner of a third wave. So I thank all of you for organizing these, the organizers particularly, and the August gathering, which is there as the panelists. The loss is mine that I'm not able to physically or through virtual platforms interact with you due to the other preoccupations. But I request my colleague, senior scientist in ICMR, Dr. Tanu Anand, to highlight various aspects of the surveillance activities. Most important being, how do we network? How do we partner? Not only amongst the professionals and the interventionists, but also engage the community meaningfully. Thank you. All the best.
That was actually very generous of Dr. Samiran Panda to send us this message. Dr. Tanu Anand, would you want to take it forward?
Thank you, ma'am. I would take this opportunity on behalf of Epidemiology and Communicable Disease Division of ICMR to thank all the organizers for engaging us in this very pertinent topic. COVID-19 has been a very complex disease in terms of its epidemiology, though we are into 18 months of this disease right now, and we have faced 2 waves of pandemic. The epidemiology of disease has guided various policy decisions all throughout this pandemic. Right from its first identification way back in December 2019 as a cluster of unknown cases of pneumonia, which were linked to seafood market, though its origin is yet under investigation. epidemiology of its spread, transmissibility potential guided WHO to declare it as a public health emergency of international concern in January. In the very initial phase of the pandemic, India took a very stringent steps in the form of national lockdown, if we see, which were basically with the emerging evidence from the other countries that very early in the phase of the pandemic could not only help in derouting the transmission of the virus, but also would help in preventing overwhelming of our systems. We all remember the kind of reports we got from various European and other Nordic countries where the systems, one of the best in the world, were overwhelmed with this novel disease. As we move further, our 3T strategy of testing, tracing, and tracking evolved, and we all know that how we have evolved in terms of additional testing strategy with involving CBNAT, TrueNAT, and rapid antigen tests, particularly in the containment setting. So as the pandemic has progressed, the epidemiology has guided us in framing or informing the decision makers to take the policy decisions. Very pertinently, I would say that if we look at the sero surveys, the fourth sero survey round has just been released. But if we go back last year in May and June, when the first sero survey was done, we had very limited knowledge about the disease, and we had about 0.7% of the population that was affected, which increased to 7% with seropositivity in September and October 2020. And this further increased to being 1/4 of the population in January 2021. And very recently, we have about 2/3 of the population being seropositive. So these are important indications, and they also tell us how we have come through this pandemic, though it is not yet over, but it has guided us that continued surveillance is very important. And that has also guided us for our vaccination rollout. Healthcare workers prevalence also seem to be very high as reported in the sero survey fourth round as well. Epidemiology has played a key role in management of diseases ever since we have the knowledge of infectious diseases in particular. But this pandemic has really been you can say a case study sort of, because we at least to the best of my knowledge, I've never seen a disease of such evolutionary epidemiology as it is being seen in this case. And we still have many newer unknowns emerging every day or constantly emerging in terms of variants, if you say, or vaccine escape phenomena, if you say, or if it is about the transmissible potential, etc. So just to summarize that epidemiology would be the key to further guide us as we move forward into the pandemic. And as the pandemic generalizes, our focus has already been demonstrated, has changed from a nation-based approach to a more localized-based approach, and local level data, as Samiran sir has also stated in his message, that it is more localized data generation which is going to guide us for taking the prevention and control measures. Responding to your second question, I would say that this has again been a highlight of this pandemic, where we have gone beyond medicine, and we had to go beyond medicine, because medicine can only prevent or cure the disease, for which we did not have answers in this pandemic, being it a novel disease. Very recently on Doctor's Day, a paper was published in Lancet Global Health based on mathematical modeling, where they have shown, in the wake of a limited supply of vaccines, particularly in the Indian context, how we can prioritize particularly the vulnerable populations. And similarly, there have been models with respect to third waves and other future waves that we are going to, if at all, encounter in the future. So field of mathematics and other statistics have been a key in this case, Previously, also during the first phase of the pandemic, there have been various predictions. I won't say that they are very accurate. We have to take them with caution, and their accuracy is limited with the availability of data and many other factors, but they do guide us in driving or informing the decision makers for the decisions to be taken. For instance, there were a lot of you can say worry about the third wave being affecting the children, but the current Sero survey findings depict that similarly children between 6 to 9 year and even 10 to 17 year have the same kind of sero prevalence as those of adults. So they have been equally affected, if not more, as compared to adults. So these need to be very timely. Surveillance need to be continuous to guide us in this. And in that case, the field of mathematics, statistics, physics, particularly in epidemic forecasting and modeling, plays a very important role. Similarly, this material science and biological sciences have played a very important role in discovering new molecules which could be used for preventing replication of SARS-CoV-2 viruses. Material science in this context has been used for designing of PPEs, gloves, masks. Mask was a non-pharmaceutical interventions that came very early on in summer of 2020. So this presents a very good case study of how an interdisciplinary approach among these fields is very pertinent. To end my answer, I would just like to state that though the international borders are closed, but the pandemic has demonstrated that the global scientific communities has not closed their borders and have shared their experiences all across the world, and which is very pertinent in this kind of disease where every minute, I would say, there is a new information emerging, and which is very important for us to actually frame a public health response. I thank you once again for giving this opportunity to discuss with you this important issue.
Thank you so much, Dr. Tanu. There's a lot of insight that you have provided, and there are a couple of questions that one would want to ask, but we would defer to questions till the end of the entire session when the panelists have already spoken. I just wanted to remind the participants, and in case that they have questions at any point of time, they can just write it at the Q&A section, and we can take it up once the panelists have provided their insights. Moving on to our second panelist today. Our second panelist actually does not need any introduction, but I would not let go of this opportunity to introduce her. She is Professor Priya Abraham, who's the director of National Institute of Virology, ICMR Pune. And since January 2020, Professor Abraham is leading various aspects of COVID-19 diagnosis and characterization of virus at NIV. Initially, the only testing center in the country for COVID-19, NIV has led the diagnosis pillar of the epidemic response of the country, not only by supporting guidance for testing, evaluation of kits, and being a major testing lab itself. Professor Abraham was earlier head of Department of Clinical Virology at Christian Medical College, Vellore. She is also an MD and PhD from CMC Vellore and has more than 125 publications in peer-reviewed journals. Welcome, Dr. Priya Abraham. And also, Dr. Abraham, as NIV has been engaged in virus characterization, our question to you is based on that, and wanted to know, what do you think? How would the genomic variants shape our response to the pandemic, especially in terms of the testing strategies, vaccine effectiveness, and surveillance strategies? Over to you, Dr. Priya. Ma'am, you're muted.
There was some background. Thank you very much, Dr. Archana, and I'm very happy to be on this program, and greetings to each one of you. In response to your question, while vaccination and public health and social measures are vital for this ongoing pandemic, the genomic surveillance, as we have seen, has played a pivotal role in identifying and monitoring novel variants that have impacted on the spread and the control of the virus itself in different geographical regions. It is important today that genomic surveillance should be strengthened and integrated into other existing surveillance programs in a region. It has come to stay, so to say. And it definitely would encourage the building of capacity for any particular region to identify a novel SARS-CoV-2 variant, and particularly identify variants of concern that could impact on the existing diagnostics or future diagnostics, the vaccines, and as well therapeutics that could be used in a particular region. It's also important that this information translates to public health action. And in India, for instance, I was part of the Niti Aayog meeting yesterday, where Dr. Vinod Paul has clearly mandated those of us who belong to this genomic surveillance consortium that we need to be ready with rapid response teams, not only at the central level, but at the state level. It's all well to identify variants, but what is the translational action from there on? So I would take your three aspects of downstream implications of finding a variant of concern. One is diagnostics. It's very, very important that the diagnostics we use should be able to target different genes of the virus. The assay that is being employed should be able to be directed at multiple targets of the genome. So should there be any variation in one particular region, the assay would still not fail in detecting this variant. It's also important to check out the widely used assays in a particular region for their capacity to detect these variants. So that is from the diagnostic angle. From the vaccine angle, it's very important to look, whatever be the geographical region, to look at possible immune evasion of these variants of concern from the antibodies that are generated in vaccinees. So this, in the National Institute of Virology here, we have been able to interrogate by growing the variants in culture and then allowing them to interact with the antibody of vaccinees. You know, the major vaccines in the Indian subcontinent have been Covishield and Covaxin. So we look at the antibody response and the neutralizing ability of this antibody against the variant. And world over, we have found that there has been some diminution in terms of these antibodies to completely neutralize these variants of concern. So that has to be an ongoing activity. Additionally, we need to also look at the therapeutics. There are a number of monoclonal antibody cocktails that are coming into the market as we speak. And they are therapeutic agents, and we need to see how good are these therapeutic agents against the variant of concern. That too has to be an ongoing activity. And when you asked me about, I think one element of your question was, do we actually try and synergize genomic surveillance with serological surveillance? Now, I mean, they don't absolutely go hand in hand, but they do, meet at some point, especially when in a particular area, you should find out the proportion that are still remaining vulnerable, either because they've not been exposed to the infection or they've not had the a chance to receive their vaccine, or they've not taken their vaccine. So it is important to look at that population. And as Dr. Tanu Anand had said, subsequent surveys in India have shown that the proportion of the population that is antibody positive has built up with time. Another area where genomic and serologic surveillance synergize, and to me, is when you know that the vaccine, yes, has been delivered in a particular region, and you need to look at breakthrough infections, or in a population where you think the infection had been widely prevalent, have there been reinfections? And again, we in an institute such as ours are able to look at those reinfections, look at the breakthrough infections, and look at whether we are dealing with a novel variant. It's also important to monitor certain special groups, those who are immunocompromised, because typically for them, the replication of the virus continues for a longer period of time. A replication for longer periods of time leads to the emergence of variants when the virus is there to replicate. So the special populations also need to be looked out for. So with that, I think I'll close. Thank you for your listening.
Thank you, ma'am. That was very insightful. And I also see many questions that have popped up. But again, as I said, we'll take those questions later. Our next panelist today is Dr. Rajesh Pande. And Dr. Rajesh Pande is a PhD and presently the principal scientist at CSIR's Institute of Genomics and Integrated Biology in New Delhi. His lab at IGIB is focused on integrative genomics of host pathogens, the InGen Hope project. His publications are very well cited, and his major interests include pathogens, genome architecture, host response, both genetic and transcriptional. Dr. Rajesh, IGIB is an INSACOG genomic consortium member and is engaged in genomic surveillance activities in the country. I would request you to let us know, what do you think, whether India is doing enough in terms of genomic surveillance, and what are the gaps in scaling up of genomic surveillance in the country? Dr. Rajesh.
Yeah, good evening and regards to all the co-panelists, and it is actually a pleasure to share a virtual platform with this group of co-panelists. So if you allow me a luxury of 30 seconds, I will take a step back and actually try to see when was the last time when all the national organizations came together for a response like this, which includes CSIR, ICMR, Ministry of Health and Family Welfare, DBT, DST, and name what. So this is also a time where we all came together for a purpose, and this was beyond research per se. It was towards a public call with relevance for public health. So initial bit of that's a positive thing which happened a lot, and as happens normally that whenever more than few partners come together, there is a little bit of time taken to synergize everything, know each other's strengths, pool our expertise together and work towards a solution. In this case, our goal was very clear from the start that we wanted to do as much as possible, as early as possible, as much of geographic expanse of the country which we can capture as early as possible. Now, it also comes with a background that we as a country are quite big, with different set of uniqueness to different parts of India, and that traverses through many layers of differences. So when it came to genomic surveillance, at least what has happened on the positive note in last 15 months, that now almost everyone understands or knows the word genomic surveillance, and that is a positive thing which has happened. And when I see coming to the specific aspect of it, INSACOG, for example, at this point of time, we are talking about 50,000 genome sequences which are there on the INSACOG. And almost half of them is being either on the sequencer or is being analyzed to be uploaded onto the INSACOG portal. In addition to this, there are many partners who are doing sequencing outside the INSACOG ambit. So that is at this point of time when we are speaking, we have more than 30 plus INSACOG members and 300 plus sentinel centers who are all coming together for doing a national duty. And when we come to the question of how much of genomic surveillance, it's also important to note that what is the time point we are talking about as well. That now when we're talking about, we have a relatively lesser number of cases in India, but possibly this is also the time when the genomic surveillance needs to be done at a more priority pace, because this is possibly the time when we run a chance of discovering potential variants of interest on time and potentially tracking those variants of interest and seeing whether any of those kind of comes back as a variant of concern in future. So there is all effort which is being made in that direction. Now if you ask about, if we want to understand about how we have moved along or moved towards genomic surveillance in last 15 months, broadly how IGIB sees it through the lens of INSACOG is that we need a combination of sequencing approaches, and this is basically building on the aspects which Dr. Priya and Dr. Panda also highlighted, that time taken from sample to sequence is quite important. So high throughput is also important, as well as high priority quick time sequencing is also important. So taking both of these into account, what we are also making progress towards developing mega labs or mega centers of sequencing, wherein high throughput sequencing can happen, but turnaround time is little bit longer because a specific number of samples need to be pooled together for sequencing. Should we wait for that, or is that the only approach? So then we thought of an alternatives in the form of microlabs. So can we have many microlabs almost in the hub and spoke model, wherein microlabs can do small sample number sequencing, but they can do faster sequencing because they don't need to wait for 100, 200, 500 samples for one sequencing. So there has been a great progress on both aspects, where there has been sequencing clusters which are basically driven by a high throughput sequencing. Then there has been microlab initiatives wherein priority sequencing can happen in a quick turnaround time. And why we are also kind of having this hybrid approach towards genomic surveillance, because we also realized during this journey of last 15 months that there is diversity in terms of the infrastructural capabilities at different centers, because SARS-CoV-2 has not made difference with respect to our preparedness in terms of the infrastructural settings. So we needed to also come up with strategies in terms of how can we set up sequencing in resource limited settings. And an example towards that is something when last year in November, for example, there was a challenge that can we set up a mobile sequencing which can detect the alpha variant from kind of entering into India. So we, IGIB, in collaboration with Spice Health, actually set up a mobile sequencing at the Delhi airport, and that was for whole genome sequencing for all the international travelers who were RT-PCR positive. And we were able to give, based on whole genome sequencing, we were able to have a turnaround time of 30 hours. So within 30 hours from sample to sequence, we could get an idea that whether the particular sample was alpha variant or not. So learning from those examples, now there has been a lot of microlab initiatives across India, wherein we want to go to the places or the nooks and corners of the country which does possibly have relatively resource limitations, but sequencing is required. So using the combination of microlab and megalab, that's something which a lot of progress has happened in last 15 months, especially in last few months. And that is a thing which I feel as a genomic scientist, I feel quite happy that we have made that progress. Yes, if you ask me in terms of whether everything has been achieved, no, it is a work in progress, but definitely all the largest possible group of stakeholders have come together, and the progress has been much rapid and much faster than what we could have even going back even a month or two. So the more people have joined the group together with a common objective of having a genome surveillance for the targeted group, and this has helped us to get many things in on time. For example, starting from the initial SARS-CoV-2 footprint in India, and which then moved on to cases of reinfection, then moved on to variants of concern, then moved on to vaccination breakthroughs, and now we are kind of having a close eye on possible evolution of any particular variant of interest or variant of concern. So it has been quite positive progress in last 15 months, wherein a lot of national organizations have come together with a common goal, which includes the organization which I mentioned. And yes, I must not forget National Center for Disease Control, NCDC as well. So it has been a coordinated effort which has made rapid progress. There would be further additions or further improvements as we move along for the betterment of it, possibly decreasing on the time taken for sample to sequence more and more as we move along. But I am very confident when I see around to see that we have made very positive progress on every front of it, where the sequencing clusters have been strengthened in terms of the capacity has been enhanced what it was there even a few months back. And a lot of microlab based initiatives are being taken so that we decrease the sample to cost time, reach to the places which require priority sequencing, reach to possible clinics which require sequencing. So using a multi-component approach, we have made those progresses. And of course, as we talk about genomic surveillance, we are also talking about how the sequences are matching with the global standards so that the data is shared with on the global platforms as well. So that is also a work where a lot of computational and bioinformatics effort has gone into, wherein we ensure that the data being generated is of world standard, and then it is shared, and that co-analysis globally can happen as well. So it's a multi-layered, multi-component progress which has happened, and it's a continuing process. And I can see that we are much better than what we were even last week, and the journey of positive progress continues. And INSACOG is very happily making those adaptation with respect to its improvement as we move along. So I will stop here and happy to take any queries or questions as we move along.
Yeah, I think there was. Thank you, Dr. Rajesh. This was very insightful. I think our being such a large country, most of the time the health infrastructure and the diagnostic infrastructure generally gets bogged down by the sheer numbers of it. So as you're saying that the capacity is being increased using megalabs and microlab approaches, it's very encouraging to know. I will move on to our next panelist. Our next panelist is Dr. Shibu Vijayan, and Dr. Shibu is the Global TB Technical Director at PATH. His expertise primarily lies in designing and developing private sector engagement strategies for urban health systems, specifically pertaining to lung diseases, both for tuberculosis and as a part of HIV/AIDS. His career graph spans over 20 years at various levels of health systems, starting from grassroots to ministries of health. He has worked as a technical consultant to WHO for the TB program in India. Dr. Shibu's long list of accolades include working as a field epidemiologist in Ethiopia with Doctors Without Borders project for Kala-Azar and HIV, managing the India chapter of the Global TB Advocacy, and has been the core group member of Public-Private Working Group for TB, hosted by WHO. Coming from the developmental background, Dr. Shibu, the question primarily is, in the view of these discussions that we've had today, what do you think is the role of a developmental partner towards supporting genomic surveillance in India? Over to you, Dr. Shibu.
Yes, thank you, Dr. Archana, and also thanks all the panelists. It's a great pleasure to be here, and thanks for having me. So to get your question, what is the role of a developmental partner? So the spirit of partnership has been mentioned by most of the speakers over here, and this is something cannot be tackled by one country or even the globe. So one of the key strengths the organizations like us or the development partners bring into the table is the partnership. So we can actually bring in and put together the partnerships together, and that's the area where we excelled. I would say in India also we kind of try to build partnership with FIND and also state governments within the domain of the sequencing part. I mean, I'm not getting into the science of it because there are a lot of scientists over here. But on the implementation, I would see from the development partner side, it's like provide more to do more. So that's the strength of what partners come in. So we know that this is a time where we also, as development partners and implementation partners and technical partners, we need to kind of shift our focus towards the common threat now we are all facing. So that's where we are also coming in. And we were early on in the epidemic, we also diverted our resources towards the COVID pandemic. Specifically on the sequencing part, as Dr. Pande just mentioned about the micro and mega and micro lab initiatives, which is an attempt to decentralize and also create an ecosystem where the turnaround time and the efficiency of providing results and also acting on it. Dr. Priya also mentioned the importance of acting on it with reference to the NIDI conversations. Here again, as partners, we can demonstrate models of how we can decentralize it, how we can bring in new technologies, keeping in mind about the concept of partnership, bring in private sector into this thing. So, so the best model I would say, which I have seen, is something Rockefeller Foundation orchestrated, the pandemic preparedness initiative, wherein they brought in a global partnership and we are also part of it, and many of the institutions represented here also in the panel is also part of it. I think that's the strength we can bring into the table. So to be very specific here, Path and Find as part of this overall initiative. So we are supporting government of Maharashtra, Punjab, and Meghalaya, especially to bring in sequencing at a point of care or decentralized way. With nanopore, deployment of nanopore, and then working towards that. So we are in the stages of deployment of nanopore in these places. Again, not in a large scale, but again, as a demonstration models to create what is it that take for when we put these systems in place. What are the requirements for that? What are the, and then kind of understand from that, and then provide the SOPs for, or even the larger technical and operation guidelines to scale up in the country. And in this webinar, this would be a starting point for actually creating such dissemination. In going forward also, like we would be able to share that lessons in a month or so, how we kind of how this is coming up, and then share the results from that. And we would like to extend, we'd like to collaborate with all the partners over this to take it further forward for larger scale implementation, not from a perspective of COVID surveillance, but broadly double clicking that into a more of pandemic preparedness, be it tuberculosis, be it other viral diseases. So that will become a platform for any pandemic preparedness, and also probably, as we all are speaking, to kind of mitigate any future pandemic within a 100-day frame. So that's the broader scheme we are looking at, Archana. So happy to contribute. I know that there will be more questions to the other partners because they are the heroes in this webinar. So I'm stopping there and over to you.
Thank you, Dr. Shibu. I think the most key thing that you've said is the ability of the developmental partners to be able to disseminate the information and also support the implementation wherever it is required, matter it be surveillance or matter it be epidemic preparedness. So Dr. Shibu, those points were, to me, very well taken. We are moving on to our next panelist, and our next panelist is Dr. Daniel Bausch. He is the Director of Emerging Threats and Global Health Security at FIND Geneva and lead FIND's efforts on pandemic preparedness and response. He's a trained internal medicine doctor. He is trained in infectious diseases, tropical medicine, and public health. Daniel specializes in the research and control of emerging tropical viruses with over 25 years of experience in the sub-Saharan Africa, Latin America, and Asia, combating viruses such as Ebola, Lassa, hantavirus, and SARS coronavirus. I also have had the opportunity of working with Daniel, and I think his ability to bring thoughts and ideas in very close to reality and implementation are commendable. The question that we have for you, Dr. Bausch, is that based on the genomic surveillance data, which is now emerging, how should the epidemic response be calibrated in India? And what are the global benchmarks in this regard, if there are any? Over to you, Dr. Bausch.
Great, thanks, Archana. Thanks for the opportunity to meet all of you and join the panel. And really great to be here. And congratulations for obviously the amazing work that all of you have been doing there in India. I can't claim, of course, anything like the expertise and knowledge on India, so I won't profess to be able to guide you in that particular way. And I'll take the liberty of perhaps giving a broader view of how I see the situation globally that, of course, relates to India as well. So I think, you know, as we've seen different waves coming through in India and across the world, I think we will continue to see waves. But I like to kind of think of it, we're not showing slides here, but often I show this Japanese painting that has the big waves, but also the little ripples. And then there's a couple different boats, and some of them are taken by the huge tsunami, but other ones are struggling with smaller ripples. And I think that's how we're going to see the situation in India and globally and for the coming years, really, with many challenges to come that we need to address. And consequently, as some of the previous speakers have mentioned, you know, I think that our surveillance, genomic or otherwise, is only going to be good as it can address not only those big waves, but also the little ripples, because of course the little ripples are the ones that have the potential to be big waves in the future. And so we need to be able to drive down our surveillance really onto a very local level. And that implies, of course, the use of different tools. Our focus here is on genomic surveillance, and you all probably have more expertise than I do on that specific, on the technical level. And I don't want to underestimate or understate the value of the genomic surveillance, but of course it is quite a few different tools that we need. And thinking about really what strategy and what's our ultimate destination in using those tools. The genomic surveillance has certain opportunities that we all know. Of course, the variants of concern are is a major one. There's also the opportunity when we get to a more of a localized level of surveillance and response to use genomics for molecular epidemiology and to trace cases and contacts and be able to react in a more localized way. Of course, there are quite a few other tools that we have and need to employ. So I don't want to, again, I don't want to understate the value of the genomics, but I think that we need to be realistic that, of course, the technology is not there for real-time genomics diagnosis on a very local level across most places of the world. And so that we have to be thinking about those other tools and then use appropriately PCR and RDTs and other emerging tools. The genomics, we can also think about, and some speakers have already addressed this, you know, what we're really trying to get out of the genomics. And so the biggest concern that we all have is a true escape mutant, right, that is not covered by existing vaccines. If that is our goal of genomic surveillance, of course, since those vaccines generally target the spike protein, we could do relatively inexpensive and rapid surveillance and just only looking at the area of the genome that encodes that protein. That would be helpful and perhaps more amenable in terms of throughput and cost. That doesn't mean that we would more like to completely abandon the whole genome sequencing, because we do need to keep an eye on the general phylogeny. And so I think it's a mix of different tools, a mix of different approaches that we would take with the genomic surveillance as well as other tools. Important, you know, some of the comments that I'll make now are looking forward, and you know, where do we go not only for COVID but for the next thing. And when I talk about this, you know, some people say, "What, are you crazy? You know, COVID is still with us," and I think it's going to be with us for, sadly, in my view, not necessarily as devastating as it has been, but I think that COVID is something that's going to be with us for globally for the years to come. You know, talking with John Nkengasong, for example, the director of Africa CDC last week, his first statement to me was, "Africa is on fire." And so a very bold and sobering statement. and then said, we don't really think that we're going to have significant vaccination in sub-Saharan Africa for the next couple of years. And so this is just an example of how we're going to be dealing with this for some time. But eventually we need to take the opportunity to leverage, of course, this concern for our present global fire to more regional and local concerns. And this was mentioned, I think, earlier on by one of the speakers, but we in a world where politicians and the general public had no idea what a genome was, or what surveillance or sequencing was, or no idea what a rapid diagnostic test was last year, now everyone in the world pretty much knows what that is. And so there's an opportunity really that we cannot miss to leverage this and be using this for, of course, the things that are still there and will still be there, the TB, the malaria, the other things, and trying to move that forward. There's opportunity for diagnostic development here on the R&D side. So one of the projects that we've been working on at FIND is trying to work with other partners to promote R&D for point-of-care diagnostic tools, for molecular-based diagnostic tools. These are not things that are going to be in every clinical, local health center anytime soon, but they are things that we need to develop. And we need to think about, of course, the use cases. And then it's very important, of course, the market analysis and the shaping and figuring out. It's not just a matter of an R&D challenge, but really making sure that we can create tools that have impact and can really get into the right hands. So many challenges there, and then making sure that all of this translates to policy. One of the things that I think we have to recognize right now, and I come to this point often when I'm doing interviews with the media, for example, where we talk about the Delta variant, and then the final message people ask me, so Dr. Bausch, what's your advice? And the advice remains the same, right? It's still about, okay, make sure you get the vaccine and wear your mask and keep your distance and maintain the hygiene. And so right now we haven't been able to specifically tailor public health guidance really much to Delta or to the particular variant of concern. And so we need to think about, how do we do that? What do we really want to know, and what are the strategies? And if they don't change based on the sequence data, if they don't change based on the variants of concern, then we need to think about how do we make them more impactful. Again, that doesn't mean that the value is minimized. And of course, we need to know as rapidly as possible if we have a true escape mutant that's not covered by existing vaccines. Maybe a few closing comments on even the bigger picture. I just got off calls this morning on the UK's proposal that will be broadened out on something that they're calling a pandemic radar, and how do we build surveillance systems in the long term in a global way. I think we all on this call recognize that this is going to take various tools. Genomics is part of that, not a panacea. That I've been on calls where I'll say naive politicians have said, okay, we're just going to create a system where instantly we're going to be able to, as soon as a bat has contact with a human, we're going to be able to get a sequence, and that's going to be translated around the world. I think it's going to take a lot more than that, but I think there are opportunities really, as we recognize globally the incredible severity of this pandemic in so many ways, not only lives lost, but of course, mental health and economic health. But I think there are opportunities through this pandemic radar. You'll hear more about that and how that develops through WHO and the G20 conference in October, I think. And then making sure, and a very important point, that whatever we do needs to get to, I'll use probably a made-up verb, but routinized into the general surveillance and general diagnostics. And so we're not going to be able to really develop systems, I think, and maintain systems that are meant to exclusively look for the relatively rare pandemic-prone pathogens. You're only going to get them when you have a system that allows you to, in a more daily or weekly basis, and the things that are concerning people on a daily and a weekly basis or monthly basis, to have those pop up. And so that's an incredibly important, a difficult challenge, but it needs to be worked into general health system strengthening and not be a standalone parallel system. And then, of course, technology is not the only aspect of this. In my previous position, something as the director of the UK Public Health Rapid Support Team, that's the team in the UK that responds to outbreaks in low and middle income countries. About half of the outbreaks to which we would respond to were vaccine preventable. And so, of course, we have the tool, and we're seeing that to a degree with COVID. We still have vaccine supply issues, but we'll get there eventually. So it's not only having the technology, it's also having the access and making sure that health as a broader human right is recognized and maintained and promoted. And then, of course, lastly, leadership, as we've seen, is incredibly important. And we've seen that if we don't have global leaders that take a pandemic as an emergency response on a public health level, not a political level, and I'm not implying any particular country here, I'm not getting into the politics, but nevertheless, we can see that if we don't approach it as a public health priority and not a political priority, that we inevitably get behind, and we've seen that in many areas of the world. So hopefully, I think we can take this as an optimistic message, an opportunity, hopefully a once in a lifetime opportunity that we can't miss to really shore up our public health systems that will, of course, have utility for pandemic preparedness and pandemic response, but really drive down to a much more local daily level and improve health on that localized daily level. So thanks very much, Archana. I'll stop there.
Thank you very much, Dr. Daniel. I think Archana, she has dropped out due to her bad signal. So I will be moving forward with the session by the time Archana joins. So thank you very much for the talk. Moving forward in today's event, we have announcement for two of the documents which we have developed in partnership with PATH and supported by Rockefeller Foundation. And as you can see my screen, we have developed a document on a ready reckoner on COVID-19 testing. And this document is, elucidates information on COVID-19 and its diagnosis, and it's targeted for India's laboratory personnel. And this includes guidance on molecular diagnostic techniques, which is crucial for accurate detection of COVID-19. And this also elaborates on biosafety measures, standard procedures, and to carry out validation and approval of tests, including antigen rapid diagnostic test and polymerase chain reaction PCR-based methods. Second document, which we are coming up with, is the overview of current COVID-19 test and algorithms and intended use of testing. And this will provide an overview of existing technologies available. And this will also provide an overview of the key aspects to consider before, during, and after the implementation of testing initiatives for COVID-19. So these two documents will be available on our website very soon. And we will also be sharing the link with the participants. And as Dr. Shibu mentioned, the role of the development partners is to disseminate. So this is one of the steps to handhold our laboratory personnel and our opinion makers within the Ministry of Health and other relevant ministries and departments to act as a ready reckoner. So with that, I will be handing over back to Archana. Thank you very much.
Hello.
Yes, Dr. Archana.
Yes, I can take it back.
Thank you.
Navneet, I'm sorry. I think there is a perfectly working system would always have some technical glitch while you're on a webinar. So apologies for that. So my apologies, I'm actually on my phone now. So there was, Dr. Daniel, I missed the last few statements, but as I had said earlier, you're asking us to be real and look at the capacity and the real time capacity, and then try and make decisions. Thank you for that. And now moving on to the questions, I have a lot of questions on serosurveillance, and I would request Dr. Tanu Anand to take a few questions that we have from our participants. One is, how is the serosurveillance data that ICMR is generating being used for policy decisions, and what is the action on that, if I may, Dr. Tanu?
Yeah. So I would like to state, right from the inception of the first sero survey to the fourth sero survey, we have been timely sharing the results with the central as well as the state governments, but with the word of caution that as we progress into the pandemic and it becomes more generalized as it is now, the state level estimates or conclusions to draw from the national sero survey is not valid. So we have to take with that account, though it is done in 70 districts in a similar way throughout last 4 sero surveys, but they are national level estimates and they only indicate the sero positivity in terms of antibodies. And therefore, the results have to be interpreted in the wake of knowledge that we are having about the waning of antibodies in the context of newer variants escaping the immune mechanism, and accordingly taking actions. And similarly, particularly this fourth sero survey has highlighted that 2/3 of the population is having antibody after the second wave of the pandemic. This is important in the context where people had a lot of apprehensions about the third wave. And I have seen in the question answer, there are many questions pertaining to third wave also. So it would all depend on how we go forward from here, taking this knowledge with us that COVID appropriate behavior, our vaccination strategy has to be the key. And unless we do not have an emerging variant of concern, as was noticed during the second wave of the pandemic, we may be able to avert the third wave. So we have to continue with the COVID appropriate behavior along with vaccination ramping up to avert this thing. So this has already been shared with the government, both the center and the states, and accordingly the policy decisions are taken that way.
Thank you, Dr. Anand. I was just wanting to also understand, when is this data of the surveillance likely to be published, or whether it is already available on the open?
For the first 3 sero surveys, the data is already published. For the fourth sero survey, it is under process. The manuscript is ready, so we are under. It is under submission for publication. But for the first 3 rounds of sero survey, the papers are already published.
Okay. Thank you for this information. My next question is to Dr. Priya. And Dr. Priya, a very valid point that you had made is not to integrate the SARS-CoV-2 surveillance with any other surveillances. Although that sentence in itself is complete, but would you want to put some more thought and clarity for our participants? And my second question to you is, what studies are ongoing to test the neutralizing ability of various vaccines which are presently being used in India? And if you have some insights towards that, and if you can provide us with that. Dr. Priya.
Okay, so there are, I think one thing that this pandemic has taught us in a nation such as ours, so complex and heterogeneous, is that we have been able to build up capacity or improve on capacity to deliver in terms of testing and screening. So there are a number of programs, the TB program itself, the National Hepatitis Control Program, the AIDS Control Program, all of which rely on good laboratory testing, quality, quality assurance. From the laboratory end of things, these have been taught to peripheral labs, but they were actually running with it during this pandemic. So I think the capacity that has been built up should be sustained. And as Dr. Rajesh had said, that would give us the capacity to reach further into the periphery, to involve some of the smaller labs in joining this effort towards genomic surveillance. So that's what I meant. And to answer your second question, I think you are asking us about how are we interrogating these variants, was it?
Neutralizing capacity of the new vaccines which are coming in. What are the studies which are underway?
I would not want to talk about many of the newer vaccines because I do not know how many fold difference it has compared to the prototype strain. From the top of my head, I do not remember, but I can talk about findings from India, which would be germane to the population in this country with regard to the variants we isolated. So starting with the alpha variant or the one, I mean, we don't tend to mention regions. So when I say alpha variant, I presume everybody knows what we are referring to. And so the alpha variant we found had almost equal capacity to get neutralized by the antibodies from vaccination as compared to the original prototype strain, both for Covishield and for Covaxin. Then we went down to the beta variant. With the beta variant, we have found that there's a reduction in the antibodies to be able to neutralize the beta variant, the one that came out of the country of South Africa. That was reduced about threefold in our hands. And these were studies mainly with Covaxin. If I move down to the Delta variant, again with the Delta variant, we found that the capacity to neutralize a Delta variant was reduced almost threefold, 2.7, threefold almost, as compared to the original prototype strain that made up the Covaxin. We also looked at a few of the VOIs, namely the Kappa variant. Kappa variant was reduced about twofold. We looked at one of the VOIs, which is now redesignated as an alert for further monitoring, namely known as the Zeta variant. It's a P.2 variant that also comes out of Brazil. And that also was reduced about twofold. So I would say with confidence these figures because that's what we have worked with. I'm sorry, I don't remember the other reductions, so I don't want to quote it out of context.
Thank you, Dr. Priya. That is, again, very helpful. My next question is to Dr. Rajesh. And Dr. Rajesh, just bringing out the effort which has been put into the megalabs and microlabs, and obviously this seems like a very promising, solution to the issue of capacity that we always face as a country. As I said, we generally bogged down by the sheer numbers of it. What is in your view, would this mega lab and micro lab initiative be enough to reach to the kind of capacity that is required for the country? And indirectly, what I'm trying to ask is that the 5% benchmark that we talk about of samples to be tested for surveillance, do you think this capacity would be able to do that? And apart from it, one of the questions that one of the participants has asked is that, is 5% benchmark enough? So Dr. Rajesh, over to you.
So short answer is yes, we have capacity to cover it. Now I have to elaborate on part of it because it's like a ladder, which is the the stage of the ladder we are. So the 5% is again a very flexible number because 5 number today was not the 5% 2 months back. So when we talk about 5%, that number itself is very variable in terms of what is the baseline. So if you ask me today, can we sequence 5%? Answer is big yes. Because in today's data, we have 40,000 positives, for example. 5% of that would be close to 2,000 samples. So that's not a problem to sequence 2,000 sample. Only any mega lab cluster can do it within a couple of days. But if you ask me, could we have sequenced 5% when we were at the peak of the second surge 2 months back? The answer to that is again yes and no. Because yes, no, because when we are at the peak of a surge, we, in my opinion, again this is my experience, I say that on the peak of a surge, probably sequencing those 5% is not very relevant, because as we have experienced from the INSACOG as well, that almost 70-80% of the variants were Delta variant. So if we sequence 5% at that peak of point, most of the variants which we will discover through sequencing would be something which is the predominant one at that point of time. So instead of taking for me personally, I would take 5% as a flexible benchmark. Probably that 5% should be increased to 10% when we are at this stage, because this is the time to detect something which is even present in very low frequency, so that we can be prepared for anything which may come in 2 months down the line. So 5% would be a number which is rate kind of indicator, but probably the importance of surveillance is more at this point of time when we are on the ebb of a tide, so that we are better prepared that what skill sets would we need to respond on the when we need it in that sense. The part 2 of it is in terms of capacity building. I think one important part which almost all the co-panelists have echoed is that we have also broken barriers with respect to the labs and the institutes per se. For example, for us, I have shared my microlab SOP irrespective of whether I have any formal association in any way or not, because somehow you feel morally responsible that if I can be useful, or the SOPs which has been developed in the lab can be useful to be implemented at any place, that is something which should be done. And we have literally opened the IGIB's gates to, in terms of sharing our SOPs, sharing our experience, making small videos for doing training for the places where we can't travel at this point of time. So DNA, which is a normal thing for me, would not be a normal thing for me for a place which is, say, has a background more or expertise more in chemical biology. So they are more expert, or leather biology. But all those within the CSIR network only, these all places have also done sequencing or are doing sequencing as well. So we had to make videos for steps which is from the sample to sequence, covering different aspects. And now we have come up with making a small video kind of capturing the whole journey, so that when we talk about the microlab, we also convey the message overall that it's not so complex, but it is not so easy. So we don't want to claim that it will solve all the problems, but we also don't want to say that it will not solve anything. Of course, it is an enabler for many things, and it has to be taken with that caveat that it has certain strengths, but it also has certain limitations, that it will not solve everything. And there are success and limitation example for all of them. For example, success example of genomic surveillance and its application towards detecting variants is the paper strip based CRISPR or a Feluda, which is there in the now on the shelf. We can buy it and we can use it. So this is a classic collaboration within the institute, where my colleague Dr. Debojyoti, with his work on CRISPR, he wanted to collaborate with us to see whether how sequencing based variants would help him to optimize his diagnostic assay in that way. So that way it has facilitated a lot of innovative collaborations within institutes and beyond institutes, and come up with a solution. And if we see the journey of a diagnostic kit from the lab to the market, it's remarkable, and it has gone through all the stages of approvals, and now it is available on the shelf and also as part of mobile facility. Another success example is when we implemented it at the Delhi airport. So when we landed up at Delhi airport, some of the very basic things which we are used to in the lab, we realized is not so basic at the airport. because some things are not made for or kind of not used in that way. So we also adapted on the run and we made those changes.
Absolutely.
Because the goal was clear that we have to give this sequencing output or inference as early as possible. So that's something which we have learned a lot in this. We have made sure that the learning doesn't remain within us if required, even for an hour. If I can help or we can help to any individual, any organization, and that is something the group here, incidentally, I have been interacting with both Find and Path on different capacities, and I have been one-liner from me at any conversation has been that feel free to share my SOPs without even asking for me, because this is not about the lab work or not about the institute work. It is something if we can facilitate anything, anywhere, leading to a possible genomic surveillance in a better way or a faster way, we are up for it. And my mobile number is probably all over ICMR, and I receive calls at 4 in the morning. Yes, sir, sample leke aa gaya. Okay, very nice. You have come with the sample. So it has been that way, and I'm pretty confident that we are moving in the right direction now. This learning in terms of the capacity building of infrastructure as well as the manpower training in terms of genomics. And when I say manpower, it includes both experimental and analysis. So this strength which is now has got built up in last 15 months in manpower would be extremely useful to undertake pathogen discovery programs in different parts of India, wherein we know that there has been disease load in some parts, which has been somehow have not been our priority. So it's a time when we kind of take those up in priority as well. And therein the IDSPs and all the disease maps will be very useful. And then we set up the disease pathogen discovery and disease surveillance program, because the work from the institute or from the lab, we have now highlighted that co-infections are an important modulators as well. So how do co-infections can have a role? So it's a genomic surveillance, which of course includes pathogen genome, but it should be expanded as well to include the host, because at the end of the day, we are an important incubator as well.
Absolutely. And Dr. Rajesh, your point is very well taken that, the COVID pandemic has brought the scientific community very close together, and sharing of information and even generating of information, the turnaround time has been drastically less than what it used to be. So we probably are in a new era. I had a lot of more questions, but time may not allow me to do so. So what I can suggest is to have these questions sent to the panelists and the answers sent back to the people who have asked these. So I will move on to thanking everybody here who has spent the time and patience to be here with us. So on behalf of Find team who has organized this webinar, Path and Rockefeller Foundation who has supported the initiative, I would like to express our sincere appreciation to all our panelists for taking the time out from your extremely busy schedules. All of you are busy with the COVID-19 pandemic, as Dr. Rajesh was mentioning, to discuss with us over this webinar today. I would also like to thank our participants for their interest and the fantastic questions that they have asked, though my apologies that all of those could not be answered. And a special thanks to Find to provide an opportunity to me to moderate this session. I hope that I've done the best of my ability, and also a special note of recognition to Find team who has coordinated this event and made it possible and made it happen. On this note, I would like to ask if there is any comments from or any additional suggestions from our panelists that they would want to say before we close this webinar. I'm opening the for 2 or 3 minutes for anyone for any comments if there are any.
I just wanted to thank you, Archana, and the Find team for putting this together. I found it really useful. I really learned a lot. So thanks to all the panelists. That, as I say, I really learned a lot and admire what you're doing. So thanks very much.
Thank you so much, Daniel, for being present here. I know it's an odd time and given your schedule. Thanks a lot. Thank you, everyone. And on this note, I wish a very peaceful and restful weekend. everyone have a good day. See you soon.
I wish we could say weekend, because that is something which has been lacking for the last 15 months.
Yes, it's a weekend to be able to work peacefully, Dr. Rajesh. That's where we've so, thank you.
So it's more of like taking the lab on the weekend to home and then bringing being in the lab the other 5 days.
Yes, that's
the
peacefully
concept
working.
of a weekend has changed.
Yeah, exactly.
Yes, Dr. Priya, we are into a new era where, where personal life ends and work begins. There, it's a seamless transition. So thank you so much for being here, and thank you, Dr. Anand, and thanks a lot.
Thanks. Bye-bye, everyone.
Bye, everybody.
COVID. Over the past year, access to fast, accurate, and affordable diagnostics have helped to interrupt disease transmission and track the effectiveness of public health interventions.
What COVID-19 has done is it has exposed sort of the impact of years of sort of neglect in testing for all diseases, with kind of diagnostics being one of the weakest links in the care cascade. And at the end of it, it is the people living in low and middle income countries that are disproportionately bearing the burden of this.
Without diagnostics, we're flying blind.
Without, appropriate diagnostic tools, devices, therapeutic and vaccine, we cannot fight this.
I think what we've seen is that the real issue in many countries is the limited testing capacity. And even when tests are there, they don't always get used or optimally used. And even if they get used, they don't always get reported. Even if they're reported, the right treatments may not always be available for patients who need them. So this tells you that this is not only an issue for COVID-19, but really an issue that we start seeing in many other disease areas.
We have learned a lot about the way different agencies can work together to solve problems in real time.
Member states need to work together and have a coordinated response. And this is needed in order for us to increase our efficiency because our health resources are limited.
And it's clear that the diagnostic industry has a responsibility, but also when you think about it, an opportunity to engage in global health in a more active way.
The community is the first point where the diagnostics should take place before, with a very well-knit referral system for confirmation at the health facility and also enrollment into treatment.
So this testing nationalism and broken supply chain demonstrate the need for change in manufacturing toward a more focused, resilient, effective approach and based on solidarity, and also with the objective of making sure that countries can help themselves.
We need to strengthen the global partnership to encourage and leverage locally developed innovations and facilitate technology transfer for strengthening global supply COVID-19 diagnostic and be prepared for the future pandemic by leveraging and building manufacturing capacity in member countries and of course in least developing countries.
I really see an important role for FIND to play across this value chain, across the ecosystem, to ensure that we have better, more innovative, cheaper, more widely available diagnostic tools.
So we need a comprehensive fully funded strategy for diagnostic testing.
This is the moment to build bridges, to involve all stakeholders in the discussion.
And urge all governments and partners to invest in diagnostics as a critical component of health. Working together, we can build a healthier, more resilient world.